Hi friends, welcome. My name's Kim Adamski. I'm an HIV prevention specialist at the Hartford Gay and Lesbian Health Collective. The Health Collective is located at 1841 Broad Street in Hartford, Connecticut. We offer a lot of sexual health services like STD testing. We do PAPs, we do breast exams. We also have a dental program, and we have educational programs that focus on LGBTQ health and related issues. One of which you have obviously tuned in today. We have folks from the Center for Advanced Reproductive Services, also known as UConn Fertility, here to talk to us about IVF, or in vitro fertilization, as the very first installment of our LGBTQ family building series. So who wants to introduce themselves first?
I will.
Okay.
I'm Dawn Sampson. I'm the financial service representative, so sometimes I'm the bad news. I do try to make it the good news, but I'll be the person that can, talk about costs and anything else insurance related to family building.
Okay, I'll go next. My name is Kathy Paniati. I am a nurse, and I am one of two nurses in the third-party reproduction program at the center. I would be your primary nurse and kind of take you through start to finish, whatever your medical plan will be.
And I'm Dr. Alison Bartolucci. I'm the lab director. So I'm sort of the end of the road for most patients. After you've seen Kathy and Dawn, I'm in charge of the actual services that happen in the lab. So egg freezing, sperm freezing, and the fertilization processes.
All right, thank you so much. So what is a just really quick elevator speech of what the center does, like what its services are?
Okay, what we do is, I think the briefest thing I could say is offer options. There are many options for all people, straight, gay, trans, anyone. We offer options, we offer hope, we offer medical procedures that can help you build your family.
Awesome. So we're going to talk today about IVF specifically, in vitro fertilization. So what is in vitro fertilization in like layman's terms?
I think that's me, right?
Yeah.
Okay. So in vitro fertilization, I mean, in vitro means outside of the body. So it's fertilization, it's adding the sperm to the egg in the laboratory instead of in the fallopian tube. So typically, historically, it was developed to treat patients with infertility. It has really evolved as a tool for many other patients in terms of fertility preservation, genetic testing, and things like that.
Yeah, so it's not only used for infertility, but for folks who want to make sure that the fetus doesn't have like a hereditary issue, or of course, as we are more focused on LGBTQ folks who are facing various obstacles to conceiving. Okay, cool. So just a little more about IVF. What is the procedure like for folks who undergo it? How does it start?
So the patient that's providing the eggs has to go through, Kathy might need to talk about this, but they go through a period of time where they undergo injectable medications to make them ovulate multiple eggs, because we do need a lot to make embryos. So they'll go through the hormone treatments, and then once they get ready, so it's very similar to what happens naturally, it's just times 100. So, or not 100, but so there's, instead of one, there's like anywhere from 10 to 20 eggs. And when the ovary becomes ready to, the equivalent of being ready to ovulate, but it's being tracked, they, instead of allowing the ovary to ovulate, they come in and have a procedure. It is technically a surgical procedure, but it's pretty minor in terms of risk. And the ovaries are aspirated, and the eggs are in that fluid that's aspirated from the ovaries, and that's what goes to the laboratory. And at the same time, the sperm is produced either in the form of a fresh sample at the same time, or we can use frozen sperm, so we thaw the sperm. And then the people in the laboratory, essentially just put them together and then watch the embryos grow. And then we can do many things. I mean, we can select them for transfer, we can freeze them, we can freeze the eggs, we can freeze the sperm, depending on what the patient's needs are.
And can you freeze those things indefinitely? Is there a time limit on that?
Yeah, in fact, we're using the word freezing, but it's technically called cryopreservation. And that is because it's not freezing. There's no ice formation. It's the cells and the embryos are treated so that they are essentially frozen in time, and they do not expire theoretically. So they are frozen, or they're stored in temperatures that are lower than where any biological activity can occur. So if someone freezes their eggs at 32, those eggs are 32 for as long as they remain frozen.
Okay. So I assume that, well, I guess I shouldn't assume, but probably couples in which one is a biological female are the ones that are most likely to undergo IVF?
Yes, I think, although I would say 40 to 50, maybe 40% of our couples do have male factor infertility as well.
Okay, gotcha. And it said you facilitate or assist with, like a gestational carrier. Is that something you have to collaborate with a different organization with? Is that something you have in-house? What's the?
So we, before we get to the IVF process, the patient starts by calling us, making an appointment. They meet with one of our board certified physicians, and they go through multiple screenings, medical screenings, psychosocial screenings, genetic screenings, to determine what plan is best for them. And then the person who's providing the female gametes may undergo IVF or insemination. So there's multiple plans, which starts with a whole lot of screening and a whole lot of planning. For gestational carriers, we do manage that process here. Some men or couples who need gestational carriers come to us with a carrier in mind. It's their sister, their neighbor, their friend, but we do collaborate, as you said, with other agencies in the area that find the carriers for us. Okay. And then your doctor and the third-party reproduction team here will screen that carrier to make sure that they are not accepting any risks beyond what is reasonable, and that it's a safe situation. So.
Awesome.
Yeah.
Okay, so what options, I know that, like you said before, for gay men to have a baby, it can be very time consuming and expensive. What options are available for gay men to build a family? All
right, so gay men need two helpers. So third-party reproduction is when you need more than two people. And gay men need two women to help them. They need an egg donor and they need a gestational carrier. It is not legal or advised that the same woman be both the biological mother and the carrier. There's too many ethical considerations with a woman giving up a child that is biologically hers. So that would be two separate women. If it's a single male, they provide sperm. It's usually frozen. The FDA regulates third-party reproduction because this man, although he will be the parent, becomes a donor to the gestational carriers. So there's certain lengths of time that we need to have the sperm in quarantine prior to transferring their tissues to a gestational carrier. But technically they would find an egg donor either through our donors that we screen here. We work with egg banks, and we work with agencies that help them to find a donor that meets their criteria. And
so it sounds like
donor,
there's like a lot of working parts.
there's a lot of working parts. There's a lot of people. I say it's the best, probably the best and the worst of all possible things you could do. There's a lot to it, but the reward is amazing. I think the planning, the screening, and the getting to the cycle is the hardest part. I think once you start cycling and doing the medical, the medications and the medical procedures, that's almost the easy part, believe it or not, because there's so much planning involved. But we walk you through it. Dawn and I, and possibly Alison, get to know you really, really well, probably better than you wanted to know us. But we understand that it's so huge. What you all will be doing requires so much extra. And we get that, and we want to give you as much extra attention as we possibly can. Because it's a lot.
Oh, yeah. Okay, so it sounds like for lesbian couples, there's a little bit less moving parts there. So what's involved there?
So I think there could be less moving parts or more moving parts. Typically, with two females, we have more parts, more possibilities, perhaps, depending on whether or not the woman is single or has a partner. So that will determine the plan. Sometimes they both come in wanting a part of the process. And we would offer shared conception, or Dawn said, reciprocal IVF, which is where one female member of the couple provides the eggs and the other female carries the pregnancy. So one has a biological connection and one has a genetic connection, and it's pretty cool. It's pretty awesome. If women who are in a same-sex relationship need a helper as well, they need a donor, but perhaps they come in for their screening and we find out that they also have underlying fertility issues. Sometimes having a female partner opens up the door for somebody else with eggs and a uterus to step in and start the process. So they can do inseminations, IVF on their own. One member of the couple uses donor sperm and has IVF if there's infertility issues, or an insemination, or like I said, the shared conception. And we have kind of multiple pieces, multiple parts, and multiple options for sperm donors.
All right, that's cool. So something that I think a lot of people wonder about, or even don't think that they can do, is trans folks having biological children. I think that, I mean, like I said, I don't know a ton about IVF, which is why I'm really glad you're here, even just for myself. But, you know, the use of hormones for transitioning probably has an impact on fertility, right? And of course, surgeries would further complicate that. So what are the options there?
Okay, hormones certainly impact fertility, but the good news is that these effects are not always permanent, and many times trans men can, first of all, I'll just going to go back a second. Fertility preservation, we strongly advise for people who know at an early age that they may want to have biological or genetic children. I think we can't say that enough. We offer fertility preservation starting at the age of 14. We work closely with the Children's Hospital that I am blanking on, Connecticut Children's Medical Center. Yes. I'm so sorry. Where most of these patients start out with their screening and their psychological consults, and they come to us and we preserve fertility. So that, I think, is the ideal situation, that you know early on that you may want to have children and you preserve your fertility. Otherwise, if you've taken hormones, we can stop the hormones. Typically between 3 to 6 months off of testosterone, ovarian function will usually return. Sometimes if you're on testosterone cream as opposed to injections, it's a much shorter time. In fact, we've done cycles for trans men who've been off of their testosterone for 5 days before starting ovarian stimulation. So it's possible. It's not guaranteed that ovarian function will return, but it's very, very possible.
Gotcha.
And depending on what surgeries you've had and also who your partner is and what hormone therapy they're on, if any, or what biological pieces they bring to the party, that determines the options as well. Trans men who have retained their uterus can carry a pregnancy. In that case, testosterone would have to stop during the pregnancy, but it's very possible, and it's awesome.
Yeah, no, it sounds so science fiction, all this stuff we could do, but it's awesome.
We have been doing a lot of sperm freezing for trans females as well. And, you know, I think there's not as encouraging data in terms of the reversibility of the hormone treatment. So it's variable. There are some trans females that will have sperm production after stopping the estrogen therapy, but some don't. So the overwhelming recommendation is to do sperm freezing before starting their hormone therapy. And again, we're seeing a lot of teenagers and young patients who, I mean, the parents and the providers should really be commended for counseling them about this, because we are seeing so many more coming through, and the fact that they've considered this is really remarkable.
Yeah, no, that's really forward thinking. I mean, when I was 14, I wouldn't have been like, yeah, my eggs, these are really important, right?
Right.
Okay, so back to what you were saying about like psychological considerations and like screening. What kinds of considerations are involved there?
Okay, so we do medical, genetic, and psychological screening. What we mean by psychological screening is more of a psychosocial educational consult. It's not an evaluation of any kind. When you walk into a medical facility, kind of the whole thing changes. We have people who have been attempting pregnancy, perhaps with a known sperm donor, or doing home inseminations, and they may need a little extra help. So they come to us, and we find that we have a decent amount of people who are offended by the screening sometimes because it feels discriminatory, and we understand that. But something we want you to know is that any couple who comes in and needs, or single person, regardless of their sexual orientation, this psychoeducational consult is required. We have the responsibility to educate everyone as to how using a donor will impact them, will impact the child, will impact, your parents, how it impacts the donor. So you can think of everything there is to know about it, make informed decisions going forward, ask questions, rethink options, having an identified donor. When you come to the center with an identified donor, your brother or your neighbor, it's a very different consultation than it would be if you used an anonymous donor, egg or sperm. You're never going to be sitting across the Christmas table from your anonymous sperm donor who you now hate, after 10 years of loving. And it's an awkward situation, or you're scared that your sister who you just had a falling out with is going to tell your child who you haven't told yet. So we want to talk about all of the what if types of scenarios prior to there being a child in the mix. And it's our responsibility to you to let you know everything we know about the process. So you can say, you know, yeah, I understand all of this and we've thought of all of this and we're good to go forward. Or, you know, I never thought of that and we may need a little more time, or let me ask you some more questions. So it's conversational. There's no evaluation at all. And we want to just give you as much information as you can so you can make as informed a decision as you can.
Yeah, 'cause it's a big decision.
Yeah, it is. And there's a psychological component or psychosocial component, I'll say, to receiving a liver or donating a lung.
Yeah.
And it's required for donating any kind of human tissue, which eggs and sperm are.
Yeah, absolutely.
Yeah. And I will say that many times, most of the time, if not all of the time, we hope you learn from us, but we also learn from you. And everything we hear from you, positive or otherwise, helps us in our process to provide the best care for you. And so it's a two-way street, and we want to know everything from you that we can do to make this process easier for you, because it's hard.
Yeah, yep. I know that you mentioned that you do also work with couples in which one or both have HIV. How does that process go?
So, you know, there's a bunch of different variables, but the bottom line is that couples who have HIV can still conceive and be biological parents. So there's, you know, if the sperm provider is the patient that has HIV, there's actually a lot of options there. Most of it does involve treatment or intervention. And the most effective and the one that we use is actually in collaboration with a lab up in Boston, in the Boston area. And what they do is, so what they found is that the viral load, all the patients who have HIV are tested for the amount of HIV or the viral load. And the viral load in the semen is not necessarily the same. So you could have a low viral load from your blood test, but have high amounts of HIV in the semen and vice versa. So they actually test the semen directly. And what they do is they take the semen, they freeze it, and then test it. And they keep doing this. They keep collecting samples, so that when they find the one that has no virus or very little virus, that's the one that they send to us to use for treatment. And the transmission rate is very low. So like I said, it does involve intervention on our part. So it requires IUI or, you know, intrauterine inseminations or in vitro fertilization. But it is possible. It's possible to use a gestational carrier. There's more to consider. The carrier would have to be counseled. Typically, anything that's anonymously donated, or not typically, but always, if it's an anonymous donation situation, they're screened for HIV and not eligible if they're HIV positive. But it's different if it's a known situation. There can be some exceptions made. And if the person carrying the pregnancy is HIV positive, again, there's a lot that they've done in terms of pharmaceutical management of that. And, you know, really the focus is transmission to the baby.
Right.
And the evidence is pretty strong that when the preventative measures are put into place, the risk to the fetus can be less than 2%. So it is possible. Again, like what we were just talking about, you do need some help,
Right.
but it is possible.
Yeah, I mean, I've read that fewer and fewer babies are being born with HIV to HIV positive parents. So
yeah, there's a lot of work being done there.
Yeah, that's great.
Yeah.
Now, misconceptions about LGBTQ parents and IVF. What are some questions and misconceptions that any/all of you come across?
I think I touched on it a little bit ago. I think sometimes the misconception, and it is definitely a misconception, although we understand the reasoning, is that the process is so hard because you are gay or trans or queer. It's hard because donors are required, and there are many federal regulations along with protocols that we have here at the center for your safety and everybody's safety to provide safe care. So it seems like you guys have to do a lot extra, and that's factual. But I want to just say that anybody using a donor or a gestational carrier follows exactly the same process. It has nothing to do with who your partner is, 100%. And I think the other misconception is that there are limited options when in fact there are many. And that's the good news. That's the good news. There's many options where people spent a lot of their lifetimes thinking that there wasn't. And we're really excited.
Yeah, I mean, more and more people are finding, I mean, more and more LGBT couples are choosing to build families now than I'm sure even 10 years ago, right?
For sure.
So that's really encouraging.
For sure. For sure.
All right, so the big one, well, not the big one, but a big one, cost. How do people finance this? What kind of costs do they face? How do they deal with this?
Well, that's a difficult question because, you know, anyone that comes in, I treat them as an individual. I don't, you know, I don't say, well, this person has Blue Cross, they're not going to cover it. I make sure that every single person that comes in, I call their insurance company. And if there's any loop or any way that I can not get around the process, but if there's anything, if there's any benefit there, I will find it. Unfortunately, especially in this day and age, a lot of the insurance companies simply just don't cover it. They look at, and it's pretty much through the card, all the insurance companies, they don't feel that, just take a couple that wanted to do a shared conception, which is, you know, the taking the egg, making the embryo, and then transferring into their wife. They term it as not medically necessary, which means, you know, they're pretty much saying that, well, they don't have to do that. You know, they haven't got into that mindset yet that, well, it may be medically necessary. You know, one of the party doesn't have any interest in being pregnant. So a lot of the time, that's the loophole that the insurance companies have for not paying. Here at the center, we are cognizant of that, and you know, we offer a very good discounted rate for our self-pay patients. So that is usually 35%, and we try and make it affordable in a sense that we can usually do it in two parts. So maybe the first part we'll do a freeze-all cycle, and we can offer a discounted rate for that, and it's based on income, joint income. So, you know, depending on what you're making, it can be anything from $8,999 up to, you know, couples that make well over $175,000. Then it would be $12,999. So it's affordable. A lot of people have pulled from their 401ks. We do offer CapEx MD, which is a loan company, which will give you a better rate than a credit card. In fact, their rates are pretty good. Depending on your credit score, their rates are between 7 and 12%, which is a lot lower than credit cards. And they'll also let our patients make the payments over a little longer period of time so that monthly payments aren't as shocking for them financially.
Okay, so there are definitely some ways to make it more attainable for folks.
Absolutely.
That's really good. And actually that did cost less than the general cost was a little less than I thought it would be. So, all right, it's really good that you must spend so much time arguing with insurance companies.
I am, and Kathy will attest to this because she hears me screaming, because our office is across the hall. I warrior for my patients, and I'm proud to say that I actually recently managed to, with one of our male couples, managed to get all of his embryology covered because
Yes.
I was, yeah, you've got to.
Godspeed.
You know what, in this day and age, I'm quite appalled by the fact that we still have to have this conversation.
Oh, trust me, I agree. The fact that we have to talk about costs for medical things is, whew, but it is the way it is, so we do what we can. All right, so what questions do you most frequently get from people who are interested in IVF?
Financial questions?
Any questions?
Questions.
All questions.
Well, we just covered mine.
Yeah.
Yeah, that's probably the most frequent question, because that's a question we all would ask about anything. How much does it cost?
It's important.
I have to say, there's literally nobody on earth you want other than Dawn fighting your insurance company.
All right, I'm gonna keep you on speed dial then, okay?
What's that?
I'm gonna keep her on speed dial then.
Like, she will get it done. And our patients can attest that she finds benefits that they didn't even know existed. So yeah, she's with a fine tooth comb for sure. I think another question is, how long does it take? I'm calling today, when will I be pregnant? I think typically, depending on your medication plan, it's probably safe to say about 3 months, at least. I'll say 2 to 3 months, once we get all of the appointments made, all of the pieces come together. If you are bringing a party to the table that lives out of state, that will take a little bit longer. With COVID, one of the good things that's come out of it is that we've gotten much better with our telehealth services. And we are able to do things remotely that weren't possible before, we hadn't latched onto before. So we are willing, when it applies to the situation, to screen people over the phone whenever we can, do medical appointments out of state whenever we can. So I would say it's a couple month process, at least from start to finish, depending on what your plan is.
Now, I know that a lot of people talk about having to do it like multiple times and stuff. Like, how often does it work the first time? How often does it take a lot of tries?
I think probably, I'll go 50 to 70%.
Oh.
Depending on your
bad.
plan, it happens the first time. I'm not exactly sure why this is. Alison can probably attest, but for subsequent IVF cycles, the success rate is a little bit higher, I believe. But many times when our gay and trans population comes in, they don't have medical infertility. They have more of a social infertility. We need other people and we need technology. So the rates are really great. And if we uncover fertility issues while you're here, it's a bonus, and you're in the right place. So you came perhaps because you needed donor sperm and you had no idea that you had, primary ovarian insufficiency, and simply because you needed the donor, you're here and you have access to care that it may have taken you, 10 years to realize otherwise, because of not a lot of education about female fertility. So I think walking in the door is a bonus. But yes,
all your bases covered
all the time, all the time here. Yeah.
All right. Any other questions that you all get? Do you get any really common questions, Alison?
So the most common question I get asked from all patients is, how do you choose the embryo? So we always choose, we always transfer, or most often transfer just one embryo. And by far, everyone says, how do you choose which embryo to transfer? So, I'm talking about a process that's way at the end. So after all of these things have been put into place and we have embryos growing in the lab, and either your gestational carrier or your partner or you is there for the final moment, is the transfer of the embryo back to the uterus. I mean, that is what everyone has worked so hard for. And the embryologist has to choose which one to put back. And there is a process. A lot of it is, years of experience in looking at embryos, but there is a process. So they grade the cells and how much the embryo has developed. We look at it while it's growing in the lab. Sometimes we get consensus. Multiple people will take a look. We're all like major geeks back there. And this is our bread and butter. I mean, we live, breathe embryo development. So we really go crazy when watching it. So that's our favorite thing to do too, is to take the embryo for transfer. Yeah.
Okay, so I noticed you said you only implant one embryo. That I always hear about people that undergo infertility treatment and have like a ton of babies or like multiples.
And that's why we usually just do one.
Okay, so is that not common practice, or is that just not your specific policy?
It's an evolution. So we've grown, we've evolved for the better.
Course.
And we didn't know a lot, and we didn't have as evolved technologies. So the success rates weren't always 50 to 70%. And there was a lot we didn't know about implantation and embryo development, or even techniques inside the lab in terms of culture and air quality. So if we transferred one embryo, we didn't have that much success. So because we didn't know what else to do, and I'm saying we as in everybody, we would just transfer more, hoping that one of them would take.
Gotcha.
Of course, the things that you see on the news is the examples of when it was too good and they all took, or two of them or three of them took. But so we've learned a lot and improved our techniques and really been able to hang our hats on the ability to just transfer one successfully.
That's great. I didn't even know that, because there's I'm also surprised at how successful the first one is, because I think there's a reputation for, like you said in the past, less success rates.
Yeah,
but,
I mean it's much higher when there's patients who are not infertile. Or
of course, right.
Donor
gametes. Okay, so I want to see if there's any audience questions, audience friends. It's okay if there aren't, though, if we're all very clear.
Oh, hi, I have a question. Hi, my name is Kristen. I'm actually a patient of the center, and I have a 2-year-old from the center. But I also moderate a Facebook group called Queer Parents of Connecticut. So I like to come to these kind of talks, even though I literally talk to Dawn and Kathy all the time. So one of the questions that has been coming up a lot in the Queer Parents group is this new Connecticut Parentage Act that takes effect January 1st, 2022. And so I was wondering if you guys could talk a bit about how the center is preparing for kind of these new, easier legal frameworks for LGBT parents in Connecticut.
Hi, Kristen, by the way. We work fairly closely with Devin James, the Yale law professor who created this bill that has become a law and will take effect in January. He is currently working on a frequently asked questions, or FAQ, as you cool kids call it, in regards to how this will actually impact queer parents. So in the past, Kristen, you may know, or you all may know that parents had to adopt their own children. So a same-sex female couple would be in the delivery room, and nobody would dare put two females down on the birth certificate, and I worked in the delivery room for a really long time. If there was a male standing in the room, regardless of who he was, if he said he was the father, his name goes on the birth certificate. Unfortunately, that's not the same scenario for our same-sex males or same-sex female couples. They have to go to court and adopt their child. To be honest, it's not always even clear, even when you're speaking to reproductive law attorneys, as to which one needs to adopt, the one who's the genetic mom who donated the egg or the one who carried the pregnancy. It's really, really difficult to even get a clear answer on that, although in the past, it's been true that one of them will need to adopt in order to go on vacation, from Connecticut to Massachusetts with one mom, and have the mom who's there. If she's not on the birth certificate, she couldn't safely provide consent for medical care, one state over. So the Connecticut Parentage Act is creating an easier way for parents to be parents, for every child to have access to their parents from birth, the legal process starting prior to birth. And it will, as far as I understand, be as simple as signing an affidavit or just signing a parentage form, for lack of a better term, saying we are the parents. And that you will both be on the birth certificate from birth. There will be no need for adoption. I think there's going to be some fear about not adopting, but we really have, my understanding is that this is going to take care of that, and you can move around the country with your children and be considered parents with this. I don't want to say affidavit, I can't even think of the word, but this declaration of parentage that doesn't exist now but will exist in January. So it's an amazing advancement and long overdue. So Kristen, we will hopefully have the FAQs as to how this will all work and how it will apply to everybody and what to do and where to go. And we're hoping to help you guys out as much as we can with that process. We're just waiting on information ourselves.
Great question.
Thanks a lot, everyone.
Cool. I didn't even know about that, so I've learned a lot of things today. Any other audience questions? Well,
yeah. I have a few questions. If nobody else has questions, not to take up a lot of space. For recipient, or for female same-sex couples, if one wanted to be the donor and have the other be the gestational carrier, how does insurance play into that? And does that tend to be covered, or is that more complicated?
It's really not, but I would never use the word donor or gestational carrier because that will automatically nullify anything. Mm-hmm. Depending on the insurances, I have found in the past that insurances that don't require an authorization will usually pay for a freeze-all. If they require an authorization, then what I have to send them is records. And in those records, they want to see where pregnancy has been attempted, or proof of there being a medical necessity. It's rare that the insurance companies will cover, but it can happen. As I said before, I'll take every individual patient and call their insurance and for hours grill them different questions and different scenarios to see if it doesn't need an authorization, can I bill a freeze-all cycle? Sometimes freeze-all cycles aren't covered. Sometimes they are. It depends on the insurance. A lot of the time, if I can get the freeze-all cycle covered and the wife or partner is on the same insurance, then usually I can get the frozen embryo transfer covered too. The bulk of the time, I'm sorry to say, it is not a covered service. Certain insurance companies, Aetna, Connecticut, they will not cover any way, shape, or form. But some of the Blue Cross policies through employers will cover it as long as they don't need an authorization.
Dawn, does any of that change if there is an infertility diagnosis discovered?
I've tried that. I've tried, you have to prove why they want to freeze their embryos. I mean, a synchronized just isn't covered. It would never be covered. But the freeze-alls sometimes dependent on, you know, I mean, their criteria for freeze-all cycles are medical illness, like, you know, someone that has cancer that needs to freeze eggs, or, you know, they're going to have some kind of treatment that can, you know, ruin egg quality, then I can usually get it covered. But once in a while, depending on the company and, you know, every individual's personal scenario, I would have to call and, you know, talk it through. And then depending on if they did have something, you know, not fertility related, like even PCOS, sometimes you can call and use that as the medical diagnosis rather than infertility.
Right.
Then sometimes they'll agree to pay, but rarely. I know. But that's why we have this fabulous self-pay price.
And I missed what the self-pay price was earlier. Can you repeat that number?
It's actually based on income.
Okay.
So it's on a sliding scale. What I require is tax returns. If you're a couple, it would be joint tax returns. If you're single, it would be your tax returns. And then depending on what your income is would determine. But it starts at $8,999, and then for the freeze-all, it would go up to $12,999, as long as you were under the 175,000 mark.
Okay, thank you.
You're welcome.
All right. Thank you for those questions. Those were really, really good stuff. So I guess it's probably about time to wrap up. So can you all provide contact info for anyone who is interested in finding out more, starting their family building journey for the center?
Yes, you can start by calling us at toll-free 844-467-3483. Any one of our front desk staff can help you with the process. If you have personal questions or want to run a scenario by Dawn or I, we're happy to take the call. So you could ask for Kathy or Dawn. We're happy to kind of talk through scenarios and help you match with the right physician or the right plan, or, you know, help you to start your process. But simply call. We have information on our website, the Center for Advanced Reproductive Services, and we're open and we're happy to help.
Great. Can you drop that phone number in the chat? We got a request for that.
Okay, I will try.
Okay.
I'm going to give it a try. Okay, let's see.
Or just repeat it. I just missed it. Sorry.
I've got the chat open. I can actually put it in there.
We're doing
Beautiful.
It's 844-467-3483. And I believe it's 1-844-HOPE-IVF. Is
Cool. Easier to remember.
stands for.
Great. And
We
I
call
am
ourselves often, but
all right, and I'm just gonna reiterate again, I'm Kim Adamski from the Hartford Gay and Lesbian Health Collective. If you have questions about sexual health, our services, anything to that effect, you can email me at kim.a@hglhc.org, or you can call me at 860-278-4163, extension 111. Thank you so much for coming live with us to our special guests and also our viewers. This was really informative for me because I came in knowing almost nothing about IVF, and now I know a basic knowledge. And I hope that you all learned as well. So thank you so much.
Thank you for having us.
Thank you.
Absolutely.
Thank you.
Have a great night, friends.
Bye-bye.
Bye.